Welcome to the Radiology Review podcast, your on-the-go source for radiology education with your host, Dr. Matt Covington, a board-certified radiologist. Please follow the podcast on Twitter at RadRevPodcast. Send emails to theradiologyreview@gmail.com or visit the website theradiologyreview.com.
Welcome back to the Radiology Review podcast, your on-the-go source for free radiology board review. On this podcast episode, I will discuss diseases of the trachea, which is a topic that has been requested by several listeners. I think this is a fantastic topic. As a reminder, you can now follow this podcast on Instagram at RadRevPodcast. Thank you to each of you who have already followed me there, or on Twitter. And on both platforms, I am posting many physics tips for the ABR core exam. I recently ran a quick poll on Twitter to ask which areas residents currently feel least prepared for in terms of ABR core exam preparation. Physics was still the number one area in which residents felt unprepared, and I am providing high-yield facts for physics that I hope may be helpful for many of you. Without further ado, let's get into the questions and answers on tracheal diseases. First question: what is the significance of a tracheal bronchus? A tracheal bronchus represents variant pulmonary anatomy in which a bronchus arises from the typically right aspect of the trachea, just above the bifurcation of the left and right mainstem. This aberrant tracheal bronchus is most likely to supply air to the entire right upper lobe, and this tracheal bronchus can also be associated with air trapping because the ventilation is not ideal given the angle of the bronchus, and that can cause recurrent right upper lobe infections due to this diminished ventilation. Next question: what is the retrotracheal triangle, which is also sometimes termed the Rader triangle? The retrotracheal or Rader triangle is a space behind the trachea located anterior to the thoracic vertebral bodies and above the aortic arch. For board exams, the most common disease entity associated with the retrotracheal triangle is the aberrant right subclavian artery, because this is the space in which that aberrant right subclavian artery may traverse. Next question: true or false? Carcinoid of the trachea is more common than carcinoid involving a bronchus. The answer here is false. Carcinoid rarely involves the trachea and is much more common in the bronchus. Carcinoid is primarily a disease of the bronchi, and I think that will hold true on ABR core exam questions. Next, what is more common in the trachea? Adenoid cystic carcinoma or mucoepidermoid carcinoma? The answer here is that adenoid cystic carcinoma is more common in the trachea. In fact, adenoid cystic carcinoma is thought to be the second most common tracheal malignancy. Mucoepidermoid carcinoma can present anywhere in the airway, although it is more common in the bronchi than the trachea. Note that mucoepidermoid carcinoma is the most common malignancy of the salivary glands, and adenoid cystic carcinoma is the second most common malignancy of the salivary glands. That brings us to the next question: what is the number one most common primary tracheal tumor? Don't think too hard about this because the answer is squamous cell carcinoma. Squamous cell carcinoma is the most common primary tracheal tumor. Next, which portion of the trachea does squamous cell carcinoma most commonly involve? And which portion of the trachea does adenoid cystic carcinoma most commonly involve? Squamous cell carcinoma is more common in the lower trachea and proximal bronchi. And I remember this because squamous cell carcinoma is a smoking-related disease, and I imagine that smoke settling into the bottom of the trachea and causing cancer there. And that helps me to remember that squamous cell carcinoma is more common in the lower trachea. On the other hand, adenoid cystic carcinoma is more common in the proximal trachea and most commonly involves the posterolateral aspect of the trachea. Next question. Which entity is more likely to invade the mediastinum? Adenoid cystic carcinoma or mucoepidermoid carcinoma? The answer here is that adenoid cystic carcinoma is much more likely to invade beyond the trachea into the mediastinum and surrounding structures. Remember that adenoid cystic carcinoma invades things in general. In the head and neck, adenoid cystic carcinoma should be synonymous with perineural spread. And in the case of the trachea, adenoid cystic carcinoma is associated with mediastinal spread and mediastinal invasion. Next, what are the most common malignancies to metastasize to the trachea? When thinking about the most common tracheal metastases, think about cancers that can directly extend into the trachea, and that will correctly lead you to deduce that lung cancer, thyroid cancer, and esophageal cancer are the most common malignancies to metastasize to the trachea. Next question. What entities can cause squamous cell papilloma of the trachea? The two most common entities that can cause squamous cell papilloma of the trachea are first, smoking, and second, human papillomavirus. If you have a single papilloma within the trachea, you would think of smoking first, and if you have multiple papillomas within the trachea, think of HPV, human papillomavirus first. Note that a squamous cell papilloma is the most common benign tumor of the trachea. Next question. A saber sheath trachea is classically associated with which entity? The answer I'm looking for here is COPD, chronic obstructive pulmonary disease. Saber sheath trachea is the term for the appearance of the trachea in the setting of COPD, where the trachea becomes narrowed in the coronal plane with sparing of the extrathoracic trachea. What is going on here is that the lungs are hyperexpanded in the setting of COPD, and that hyperexpansion narrows the trachea in the coronal plane due to compression of the trachea between the hyperexpanded lungs. The intrathoracic trachea may be something like 1/3 as wide in the coronal plane as compared to the sagittal plane with saber sheath trachea. And saber sheath trachea is considered by many to be pathognomonic for COPD. So remember, saber sheath trachea and COPD. Next question. Is tracheal cartilage located within the anterior or posterior aspect of the trachea? The answer is that tracheal cartilage involves predominantly the anterior and anterolateral aspects of the trachea. The posterior aspect of the tracheal membrane is not cartilage containing and is able to bow inward upon expiration, as can be seen on an expiratory phase CT sequence. Note that it is possible to have a congenital O-ring trachea where that cartilage is circumferential, but that is not normal anatomy. That would be abnormal anatomy to have circumferential cartilage because that posterior membrane is normally spared. And in some cases of O-ring trachea, that needs to be surgically corrected, to my understanding. Next, and this is an important question, what are 3 key questions you can ask yourself when approaching a tracheal disease question to help narrow the differential? Basically, I want to point out 3 key factors that you can use to differentiate common tracheal pathologies. What factors or aspects of tracheal disease can you use to differentiate one entity from another? The first key question to ask yourself when approaching a tracheal disease question is, am I seeing diffuse or focal involvement of the trachea? The second question is the posterior membrane involved? Another way to consider this is whether the disease is purely cartilaginous, meaning it will spare the posterior membrane where there is no cartilage, or whether the disease is circumferential and will potentially involve the posterior membrane. And the third question is, are there tracheal calcifications? So to recap, the 3 questions to keep in mind when approaching tracheal diseases on imaging. First, is the disease involvement focal or diffuse? Second, is the posterior membrane of the trachea involved? And third, are there tracheal calcifications? Let's try these out. How do these key questions apply to relapsing polychondritis? Is relapsing polychondritis diffuse or focal? Is the posterior membrane involved? And are calcifications expected? Relapsing polychondritis results from recurrent episodes of autoimmune-driven cartilage inflammation and associated recurrent pneumonia. The tracheal cartilage only involves the anterior and anterolateral trachea, and since this is a disease of the cartilage, you could predict that the posterior membrane is spared, which would be correct. Other sites of involvement with relapsing polychondritis can include the ear and nose, where you also have cartilage. If you have acute polychondritis, that can often be painful, and relapsing polychondritis is associated with arthralgias. Think cartilage within the joints being inflamed, glomerulonephritis, abdominal aortic aneurysm, and cardiovascular disease such as valvular disease and pericarditis. To recap, relapsing polychondritis would more commonly have diffuse tracheal involvement, the posterior membrane is spared, and you do not expect tracheal calcifications. Next, how do the key questions apply to granulomatosis with polyangiitis of the trachea? With granulomatosis with polyangiitis of the trachea, first, you can have focal or diffuse involvement. Second, the posterior membrane would be involved because GPA has circumferential involvement of the trachea, and no calcifications would be expected. Also, look for additional imaging cues such as cavitary lung lesions on CT images at the level of the trachea that may further point you towards granulomatosis with polyangiitis. Next, how do the key questions apply to tracheobronchiopathy osteochondroplastica? For some reason, I love the name of this disease. It just rhymes and it's long and I like it. Tracheobronchiopathy osteochondroplastica. Hopefully I said that right. This is sometimes abbreviated TO or TBO. So, first, with tracheobronchopathy osteochondroplastica, diffuse involvement would be expected, and this most commonly is a disease involving the majority of the distal trachea and proximal bronchi. Second, the posterior membrane is spared. Third, TBO presents with multiple calcified and non-calcified nodules that can cause airway narrowing. The calcified nodules are cartilaginous and osseous nodules within the submucosa of the distal tracheal and proximal bronchial walls. Let's continue. How did the key questions apply to tracheal amyloidosis? So think to yourself, is tracheal amyloidosis diffuse or focal? Can it involve the posterior membrane? And are calcifications common? The answer for tracheal amyloidosis is that you can have focal or diffuse involvement. Focal involvement is more common, and you might see a few areas of irregular focal involvement. Second, tracheal amyloidosis can involve the posterior membrane. And third, calcifications are extremely common. Now, sometimes tracheal amyloidosis can be diffuse, and there are cases where you can see diffusely calcified trachea associated with this entity. Tracheal amyloidosis is usually circumferential, so you do expect posterior membrane involvement, and the disease involvement as well as calcifications can also extend into the bronchi. You can also sometimes see multiple calcified popcorn-like nodules in the lungs, along with septal thickening and other, perhaps non-calcified peribronchovascular nodules. Tracheal amyloidosis is a high-yield entity. Go ahead and look up some images on all of these tracheal diseases because these are all high-yield for the ABR core exam. Let's review. What two entities classically spare the posterior membrane and what two entities classically do not spare the posterior membrane? The two entities that classically spare the posterior membrane are tracheobronchopathy osteochondroplastica and relapsing polychondritis, both of those are expected to spare the posterior membrane. Notice that both of these have chondro, or at least nearly have chondro in their name. Relapsing polychondritis has chondritis instead of chondro. Nonetheless, they all have that CHOND in the name, which points you to the fact that these are cartilaginous-related diseases. Because you know that cartilage is not within the posterior membrane, you can correctly conclude from their name alone, when you see the CHOND, that these entities spare the posterior membrane. On the other hand, the classic entities that can involve the posterior membrane are tracheal granulomatosis with polyangiitis and tracheal amyloidosis. Those are both circumferential tracheal processes. Next question. Can sarcoidosis involve the trachea? The answer is yes. Sarcoid can involve just about anything in the body. On CT with sarcoid, look for circumferential tracheal thickening in the setting of mediastinal and hilar lymphadenopathy and perilymphatic nodules within the lungs. That spectrum of findings can lead you to sarcoidosis of the trachea. Next, what are key features of post-intubation stenosis on CT imaging? When I think of post-intubation stenosis, I think of a coronal or sagittal plane showing an hourglass configuration of the trachea, and what that means is that you have focal narrowing, which is in the subglottic location, causing that circumferential stenosis focally, and so you get an hourglass-like appearance. Next, what is more common, congenital or acquired tracheomalacia? The answer I am looking for here is that acquired tracheomalacia is more common than congenital tracheomalacia, and the most common cause is COPD. Another risk factor for tracheomalacia is intubation trauma or prolonged intubation, which can also result in stenosis. To diagnose tracheomalacia, look for something like greater than 70% airway collapse on an expiration phase CT, or collapse on bronchoscopy of something like over 50%. But you are looking for that expiratory collapse of the trachea that is more than expected to point you toward the presence of tracheomalacia, which most commonly would be acquired from COPD or something like long-term intubation. Next question. What is Mornier-Kuhn syndrome? This is spelled M-O-U-R-N-I-E-R and second word K-U-H-N, Mornier-Kuhn. What is Mornier-Kuhn syndrome? Another term for Mornier-Kuhn syndrome that I left out is tracheobronchomegaly, because that is a very descriptive term that tells you that the trachea and bronchi are too large. Tracheobronchomegaly or Mornier-Kuhn syndrome presents with severe, massive dilation of the trachea, and often the trachea will be greater than 3 centimeters in diameter. The cause is thought perhaps to be congenital with some sort of absence or atrophy of the elastic fibers of the trachea, and this entity is much more common in men than women. This is associated with Ehlers-Danlos syndrome, and it is also associated with tracheobronchomalacia. It is important to remember that despite the trachea being very large, the trachea is also very easily collapsible. Mornier-Kuhn syndrome is associated with obstructive airway diseases in physiology and recurrent pulmonary infections. This is also associated with bronchiectasis of the lower airways. So if you are shown an image that shows really pronounced bronchiectasis in the lower lobes, and they ask where else you might consider looking, the answer they could be looking for is the trachea to see whether this is Mornier-Kuhn syndrome. I hope this was helpful for many of you. I will make a free downloadable study guide on this topic available on my website, theradiologyreview.com. You could download this and other study guides to help you with your board preparation if that is something that is useful to you. Keep up the good work and continue to study hard. Remember that you have to study really hard to succeed on radiology board exams, so prepare to succeed. I will catch you on the next episode. Content of this podcast is provided for informal educational purposes only for radiology trainees and radiologists. Medical practitioners, please make your own independent assessment before suggesting a diagnosis or recommending any course of treatment. This podcast should not be used for self-diagnosis or self-treatment and is not a substitute for independent professional medical care. Please consult your own physician regarding any diagnosis, imaging interpretation, or course of treatment.